All right, so we will go ahead and get started with our conversation.
Hello.
All right. Once again, thank you very much. While we're speaking, please feel free to continuously eat and take care. Obviously, we're talking this evening about mental health and well-being, so please eat up, drink up if you imbibe, and also stay hydrated. So we'll go ahead and get started. I have my water as well. This evening's conversation is on mental health, as I've mentioned, and it's not the easiest topic to talk about. We're going to really get into the nitty-gritty. I'm very excited to be joined by such incredible experts in the field who are going to really lay some things out for us. The overall title of today's conversation is Mind Over Matter, Exploring Our Health in the Time of Pandemic. And so before we get started, I want to just go ahead and let you all know who it is we're speaking with. So we have with us Dr. Verret Reynolds, who joins us as the president of Xavier University of Louisiana. Dr. Verret, very nice to be here with you. We also have with us Dr. Harsh Trivedi, who's the CEO of Sheppard, Pratt in Maryland, and he's also a former board member of the American Hospital Association.
Thank you.
Dr. Kwame Anderson, she's come to serve as, well, rather she does serve as the Director of Federal Government Affairs with Vertex Pharmaceuticals Incorporated, and she's going to tell us about the industry perspective with respect to mental health and employees. Thank you so much for being here, Dr. Anderson. And then last but certainly not least, we have Dr. Gerald Harmon, who is the current president of the American Medical Association.
Hey. Thank you.
I'd be remiss if I didn't say that I used to work for the AMA, but I was whispering in his ear that I was following his work even before I was with the AMA. So very much appreciate you all being here. Let's just go ahead and get right into it. And so my first question is for you, Dr. Trivedi. I want you to tell us a little bit about what you've been seeing these last years. Obviously, we've been in syndemic crises, right? The pandemic, but so much else going on. With respect to mental health, what have you been seeing in terms of trends amongst the BIPOC communities, historically marginalized and minoritized communities?
Sure. Well, first of all, I'll just say thank you so much for hosting this vital topic. When I think about the last 2 years, I don't think there's anyone in this audience who doesn't know somebody who's impacted by a mental health issue, a substance use issue, something that's going on where they're struggling. And so I think particularly I would say thank you to the leadership for Chairwoman Kelly, as well as the Congressional Black Caucus for sponsoring this, supporting this, having this conversation, as well as the National Minority Quality Forum. When I think about the last 2 years, what I would just say is we are seeing people that have never had issues with mental health showing up for the first time. We have people who had difficulties before coming in, struggling like they never have. And we're seeing a number of different things, right? So first of all, just stress, financial stressors, things where people are trying to figure out, well, how do I make it through the day? What happens? I have a family member who's now sick. I have a family member that may have passed away from COVID. What does this mean? That then leads to increasing anxiety. We're seeing depression rates like never before. Our organization, we are all throughout Maryland. We have about 387 sites. And across all of our outpatient centers, we're seeing an increase of about 40% in outpatient visits. And so when you think about that, there's an access problem. But not only that, the depression is such that people are thinking about suicide. People are having overdoses from drugs. But then what we're seeing is all the other stressors, right? So you're having difficulty at work. And so you're noticing, okay, well, work performance has gone down. Kids, you're separated from a lot of the adults that you rely on. And so we also run one of the domestic violence shelters right outside of DC. We are seeing unprecedented demand for domestic violence services. We have kids in early Head Start, and we're noticing that they are dropping behind in terms of how they're doing in those classes. They're not able to focus. And as we say all of these things, I guess what I'd say is most important is if this was just mental health during the pandemic, that'd be one thing. We were already in a mental health crisis. Mm-hmm. That was already there, right? Mm-hmm. And when you add to that the last 2 years, I think what adds to all of it is if you think about George Floyd, you think about racial equity, we have people that have multi-generational trauma that Like literally last night, you look at Florida and you look at redrawing of the congressional maps. Why? So that a certain group of people don't get to vote.
Yeah.
All of those things add into that narrative. And so not only do you have a mental health problem, you also don't feel validated like you exist or that you matter. And then you add to that, on top of the racial inequities, you have what is the uncertainty of every day, right? And whether it's a school shooting, it's what happens on the subway in New York City, it is what goes on in every community, or it's things in Ukraine, and you think, what could possibly be worse tomorrow? Then you wake up and there is. So I think all of that is affecting people's psyche. And as inflation goes up and you can't afford your rent and you can't afford a place to stay and you can't pay your food bill, all of those things matter. But we're gonna lift up from here.
Oh, I know. But I just needed you to really lay the base, right? And you laid it out plainly. Thank you for that. So what I want to do is ask your fellow panelists to tell us a little bit about themselves, and then I'm going to give each of you some questions to help elucidate what it is that Dr. Trivedi laid out for us today, or this evening. Dr. Verret, tell us a little bit about yourself, sir.
Well, I'm the president of Xavier University of Louisiana, which you might. And we do educate a number of students who become physicians. I mean, and that may be
A number.
But we also educate students who become, we send more African Americans who go on to PhDs in the sciences, in the life sciences and physical sciences. But we are a liberal audience, but I myself, I'm a scientist, I'm a biochemist and immunologist, and somewhere along the line I became a dean in something else. But I would say that my life has been educating, preparing young people who are then there to replace me. And I think we can speak about the challenges that they are meeting today and how we address those challenges.
And we're definitely going to get into that for sure. Thank you so very much for that. Dr. Anderson, tell us a little bit about yourself.
Thank you.
My silver. I had to throw that in there.
Good evening, everyone. Happy to be here. I am, I work for Vertex Pharmaceuticals, but recently left the Hill April of 2021. And my background is I graduated from Southern University in Baton Rouge, Louisiana, and moved out here 21 years ago as a presidential management fellow and started at the U.S. Department of Health and Human Services. Did that for about 6 years. And then I moved over to Capitol Hill, where I've worked for 4 different members. I've worked for Congresswoman Sheila Jackson-Lee, Chairwoman Maxine Waters, Congresswoman Yvette Clarke, Brooklyn, New York, and then Congresswoman Eddie Bernice Johnson, the 30th Congressional District of Texas. So it was my time in Chairwoman Johnson's office last year on January 6th, and I was at work. And it was the most horrific experience that I've ever had in the workplace and in life, to be on lockdown for 14 hours. I got to work that morning around 11 a.m. and we didn't leave until about 1:30 a.m. We got the call from, an alert came across our computer from Capitol Hill Police to shelter in place. And that's what started it around, I would say around 1:30, 2 o'clock that afternoon. And for hours, we were locked in our offices with no food. We could only really just watch CNN, afraid to go to the restroom, just afraid to move. I think around 6 or 7 p.m., Democratic leadership asked members to go to 1100 Longworth to check in to see what members were there. And it was a room full of members and staff. So we didn't feel safe for the member being there. We came back into the office. But I can tell you, to watch the seat of democracy unfold in front of you and not really understand the reason as to why, and really just being a staffer who believes in a cause. That was the reason that made me think twice about public service. And eventually, about 2 months later, I left the Hill because there was another incident in March on Good Friday where we had a bomb threat. So staffers are having difficult times, and the leadership noticed that and provided employee assistance for us. But now I'm on the other side in corporate, and they offer so many benefits to help us cope with mental health. And I look forward to speaking more with you about that this evening. Thank you.
I just want to acknowledge that wasn't easy to share, and I appreciate you sharing that. We're going to dig into the services you've mentioned as well.
Thank you.
Dr. Harmon, tell us a little bit about yourself and your journey.
Thank you, Mia. I'm Gerald Harmon, family medicine specialist in rural South Carolina for almost 4 decades. In fact, 39 years.
Yay.
And it seems like yesterday, but I have been practicing in a small community. We measure our growth in stoplights. When I started practicing, we had a caution light. In Pawleys Island, South Carolina, rural Georgetown County, we had 1 caution light. And now we got 8 stoplights. The traffic is overwhelming. I mean, sometimes you have to wait to turn left. It's just, I don't know how y'all get along up here in DC and
That's progress.
Chicago and places, New York City. Blessings on all of you for doing that. Anyway, I happen to moonlight as president of the AMA. And that's my moonlighting job right now. I have an interesting background. I have a 35-year military career. I did Army basic training in 1969, and then I wound up going to medical school and scholarships and all. I wound up 35 years, entered into the Air Force, and a lot of deployments, a lot of opportunities to see a lot of stuff, as it were. Yeah. And it's broadened my experience. I think it has not made me a wiser physician. I just have been very experienced, and I've had a lot of experiences that impact what we're dealing with today at this forum. I'll comment from, I'm still practicing. I still go to the hospital, take call, working. I'm not as busy in my office because I can't be. I understand that as a family doctor, there's no continuity with my patients. But I work as a hospitalist. I work in the emergency room. In a small town hospital, you do everything. If you're a family doc, you can do everything. So I'm occupational medicine, medical review officer, you name it, do all that stuff. Aerospace medicine, having a flying career too. But I wind up working in the ER, working in the intensive care. I do hospital shifts. We have a family medicine residency that's now 4 years old. I precept those folks. So I have a real varied background that I bring to the role of president of the AMA. I will tell you, one of the things we can talk about today is behavioral health issues. You know that the AMA and all of us are talking about the relationship of substance use disorder and behavioral health issues. We had over 105,000 Americans die from opioid overdose last year. 105,000. Wow. And I think everybody in this room has somebody who's, just as you talked about, someone's been touched by substance use disorder and overdose. It strikes our family members, it strikes my patients. Sometimes I don't see it coming, sometimes I wish I'd done more. It's a woulda, coulda, shoulda phenomenon. But substance use disorder is absolutely tied to the lack of behavioral health care, the lack of psychiatric care, of mental health care, lack of recognition of the needs, and lack of attention to that. So I'm very interested in what I learned today from this forum. Thank you. Thank you, Mia.
I appreciate you. I appreciate you always, and all of you taking the stance of being educators yourselves, but then also being learners of life. And that's really what I think the conversation of mental health draws up for us. Also, amazing sock game. Like your socks. your socks.
Your socks.
Yeah.
Oh, I didn't even notice I had them on. You mean
Right,
AMA
right.
socks?
Those AMA socks.
Oh, excuse me.
That's cute.
I do okay, Craig?
You did okay. You did all right.
Check the box.
Dr. Harmon, I want to stick with you for a minute, though, as we break out some of these conversations, the topics you all have mentioned. So we're going to be talking adolescent health. We're going to be talking about employees. We're going to be talking about providers. I want to start with providers. Everyone has been going through over these last 2 years. What has AMA been doing with respect to taking care of our caretakers?
You know, there's no question. We have surveys that show that this is a scary part. We were already faced with a provider, physician, a nurse shortage, a pharmacist shortage, a dentist shortage coming into the pandemic. We have data that shows that 1 out of 5 actively practicing doctors intends to retire fully from the profession in the next 24 months. 20%, like falling off a cliff. We were already short of doctors. 40% of nurses have told us they're out of here in 24 months. Another 20% of doctors said, I'm going to not retire, but I'm going to markedly cut back because I'm getting worn out. I'm getting burnout. We had burnout. 54% of doctors complained of burnout or expressed symptoms of burnout. Before the pandemic, we were already in a burnout phase. We were already having behavioral health issues and concerns about mental health issues with physicians before we threw 24 months of the pandemic on them. Now, we had a little silver lining here that doctors like myself and many in this room felt a renewed sense of purpose. 47% of them said, now I know I'm here. In the biblical sense, now they knew for such a time as this, we're here. This is what we took the oath for. Take care of our fellow human beings. We all wrote that on our medical school applications. I want to serve humanity. I want to take the gift I've been given. I want to serve it back for the good of humanity. They all said that. And if they didn't, we didn't necessarily decline their application, but we wondered why they were doing it. Well, this gave us a chance to live that dream, to be true to that signature and true to that oath. So we are kind of a renewed sense of purpose. However, we continue to beat them up. Doctors will tell you their number one frustration, believe it or not, is the dirty word in my book, and that's prior authorization. The frustration of having me suggest a treatment, whether it's a prescription, an x-ray, a procedure. As a family medicine doc, I tend to say, I need this to make a diagnosis. I tell the patient, you need to go get this done, and I send them to the pharmacy. The pharmacist calls me back and says, Dr. Harmon, their coverage does not cover this, and it's a generic medicine. They should be able to get it. But they put barriers to care. We have the average doctor having 44 prior authorizations a week. The average doctor, that includes some that only may write 4 prescriptions, some may write 80 prescriptions. But 44 interactions for prior authorization for medicines alone in a week. They spend 2.5 staff days a week just handling the prior authorization, which is an incredible impediment to access to care. So that's a frustration benefit. The other thing we're doing, and you see this in physician dissatisfaction, a lot of us blame the electronic records for being frustrating. We have data that shows that the average doctor spends 56 hours a year, 56 hours logging on, just logging in to an electronic record. It's not just their electronic record, it's the data access point so you can check on the patient's medication. So you can do prior authorization or find out what their discharge summary is. 56 hours just watching that little circle go ding, ding. You talk about non-productive. No wonder doctors are burned out.
Right.
And it works in the healthcare. The nurses have to do it. The pharmacists have to do it. So, yeah, it's a big deal. And I'll tell you that behavioral health, physician burnout, what the AMA is doing, they document all this stuff. And we have a lot of stuff on our website. We give seminars. We get webinars. I've done video tutorials on the internet. You can be an AMA member and sign up, but you don't have to be an AMA member. It doesn't cost you anything. We have a bunch of web-based seminars you can get continuing education credit for. And they'll teach you this from strategic experts and people who have done this that tell you how to do some tiny steps, whether it's relaxation techniques, all this stuff. And I can go on and on. We have lots of opportunities to make ourselves better as physicians. But we're very busy, very aware of it. And I thank you for letting me have the mic just for a moment.
I appreciate that. 56 hours, my goodness. Dr. Trivedi, so Dr. Harmon talked about burnout. We also know that stress and just overall anxiety disorders have been on the rise over these last 2 years. You run an entire health system. What is it that you're doing to support your employees?
Sure. So I'll start off. I think, just continuing along with what Dr. Harmon said, I became a physician. I signed up to take care of people. I signed up for whatever is the hardest work to be done, right? What's different uniquely about our COVID journey is we all didn't sign up to walk into a place where we might get sick ourselves, we might burn out ourselves, we may not make it ourselves.
Amen.
Right?
That's right.
And I think this is what's different is, yes, we have a hero culture where we're gonna do what we need to do to help that person live. But at the same time, we didn't sign up to step in harm's way to not go back to our own families. And I think that's the burnout you're noticing in nurses and doctors. But I will also say, when we talk about burnout in hospitals, I feel just as much, if not more, for my environmental services staff, my nutritional services staff, all the people on the front line. Because guess what? They're doing that, and they're also trying to figure out how they're going to pay their bills at home, who's going to be taking care of their child at home, what's going to happen in the rest of their lives. And so when I talk about healthcare burnout, we've been doing a number of things that I will say, it's going to sound like we do a lot of things, and I will say we need to do so much more. That's always the answer. So what have we done? We've done it, first of all, when COVID began, none of us knew what this journey was going to be like. And all of a sudden, daycares closed, people who didn't have plans of what to do. We stood up daycares at our hospital because we already had pediatric specialists. We had the ability to do so. We basically set up day camps so that staff could come in with their kids so we could make sure they knew that their kids were okay. As we got through COVID, through that journey, and people were starting to burn out, we actually set up within Maryland across our hospitals. Our state hospital association helped us, and the AHA helped us. We actually set up a compassion tribe, which was basically healthcare providers, nurses, doctors could just call in for a support group. And completely confidential, people from every hospital across the state would have a place to check in. Within our hospital, and I think this is one of the big things we have to think about, within the work environment, there's this whole notion of like EAP services. I haven't found a good EAP service in any of the hospitals I've worked in. And so we took it upon ourselves where we said, that's just not good enough. And so we actually set up a urgent care clinic for our own healthcare staff where they could come in, get evaluated, get support, get treatment. In addition to that, we thought about all those other things, right? How do you think about childcare? How do you think about elder care? What do you do in terms of having a more flexible schedule? What can you do in terms of having the ability to actually take time off? And I will say as leaders, like, yes, we have this hero culture, but we are culprits because we work 80, 90 hours a week. What are we teaching our staff, right? And so we had to get into these intentional conversations where we said, look, as your supervisor, as your leader, I'm telling you that you got to take a day off, you got to take a week off, right? You have to be able to work that in. The other things that you also need to do is to really point out what's truly important. And that also means as healthcare leaders, you have to stop doing something, right? And what I mean by that is we have all these initiatives, and I get there are regulatory pressures and you need to get things done and you've got your next whatever measure going in. At some point, you just got to say, look, I need to make sure my people are okay. And some of these things we're just going to put on hold, right? The last thing that I'll just say in terms of this is, we have 2 hospitals, but we have 387 outpatient sites. And we have people that went hybrid. And I think the other part that I'd say is for the folks that are hybrid or even working from home, they have been completely detached from everyone, right? And that's okay if you've already worked with us for 20 years and you know like who your peer group is, you know what you're doing. But if you're one of those people that just entered the workforce 6 months ago or a year ago, you are lost, right? And so we've been more intentional about trying to reach out to those folks who are new, who also haven't been to the workplace, but also need those connections. And what you find is, just because of how life works, we have people that live like in the same building, didn't know they both worked for Sheppard Pratt, right? And so we're trying to make those connections. And so I'd say in terms of what we do, it's all of that, but it's so much more. It's relaxation techniques, it's wellness techniques, it's how you re-engineer the work. And then most importantly, I'll just say, listening to the employees to figure out what could we do better, what do you need?
I like that a lot. I appreciate that. I'm wondering, Dr. Anderson, if you can build on that. So you mentioned that there's some techniques and supports that you all have within or for your staff. Can you tell us a little bit about that, or for employees at Vertex?
Sure. And you said something that I would like to segue into, which is I was onboarded during the pandemic. I came on board, tomorrow will be my 1-year anniversary at Vertex.
All right.
And I started virtual. And at the time, Vertex was 100% virtual. But one of the things that I think was helpful to me was my colleague who came on board the same time I did. We did all of our orientation together, and we continued to partner with each other along the way. So I think as companies continue to onboard people virtually, having an accountability partner helps a whole lot, because what I don't know, she helps me, and what she doesn't know, I help her, and we share information, and we also are a support system for one another. But what I really wanted to highlight is that since 2022, we started a policy called Flex at Vertex, and it allows for 3 different types of work options. The first one is on-site. Those are people whose jobs are non-negotiable. They have to go into the workplace. However, they have the ability to be able to request ad hoc remote work. So that's helpful, especially if you work in the lab and you can write your notes from home. It gives you the ability to perhaps take your child to a doctor's appointment that day, or a parent to a doctor's appointment, without requesting time off. The other option is a hybrid. And part of that hybrid of on-site remote allows our employees to work 3 days from work. So for example, our federal government affairs team works Tuesday, Wednesdays, Thursdays in the office, and Mondays and Fridays we telework. The good thing is you do not have to telework at home. You can telework from anywhere. So basically, if you wanted to go check on a parent that's in another state, it allows you to be able to do that. And lastly, we have a group of people who work 100% remote. Those are our state government affairs people who work out in the field, and they can also come in. You can reserve space. We have an app called Condeco that allows you to reserve space if you want to come on site. I think another thing important to highlight that we are doing at Vertex is they offer continental breakfast. They offer lunch monthly for our employees. We have a gym, we have a game room, we have a maternity room where mothers can go and nurse. So they've been very thoughtful in thinking through ways to keep employees engaged and to meet people where they are, because we understand not everybody is going to feel comfortable going back into the office. So you can speak with your manager and be able to come up with a solution that works for both you and your supervisor in order to meet the work demands. And then it also is helping because now at Vertex, they no longer are calling it sick days, but wellness days. And I think that puts a positive spin. One of the things that they did throughout the pandemic every 6 weeks was a touch point with employees, and people were actually afraid to take time off. So to make it work, they created global synchronous days, an additional 10 days throughout the year that they give us. We will also have the second week in August where we're summertime off. We get a week off for Christmas through New Year's. So they're very intentional about making sure that your mental health is being at the forefront of the culture of what we do at Vertex.
Well, I hope there are some employers in the audience taking notes. Yeah, that sounds fantastic.
Yes.
Thank you so much for laying that out. Now, we've been talking a lot about people who are grown, right? I really want to talk about the next generation and those who are coming up in the ranks. Dr. Verret, talk to us about what's going on with Gen Zers, our young folk.
I would speak about Gen Zers, but also about even going back into the 90s before that, we began to see on college campuses increasing needs for mental health services, students who are coming to college with different behavioral issues, needs for medication. And so many colleges and universities were increasing their staffing. And there was a limit to how much they could provide. So they would rely upon do the immediate work on campus, but also relating to with practitioners outside. In the last few years, I'm speaking the last 5 to 10 years, including during the pandemic, those numbers are really shooting up in a very peculiar way. And it's not just on college campuses, because we're seeing data about the numbers of our young people, adolescents and young adults who are harming themselves, showing up in emergency rooms, which is something that you can't fudge that. That's hard data. That's saying that something very dramatic is happening that says the society that we have right now is not kind to those coming of age right now. I would almost say maybe toxic. But one of the things that we approach in college is that we also approach it with certain humility. Humility because we don't fully understand the cause. There are many factors at play in this. Some of it is clearly the stresses of too much information and too early before I can process with my brain, but also the pressures of coming of age, but also a certain hopelessness which shows up among adults. And that hopelessness that we are passing on to our children, that are saying, what is the world that you're promising me? I always like to think of the election of when Obama was elected, we think of Obama's election as clearly it was racially significant about how America dealt with race. But it was also an election where young people 18 to 35 voted at huge numbers. It was not unlike the 60s and the 70s where the young people came and told the older generation, we don't like the F that you're offering us. In many ways, they did it politely by voting. Clearly, we were seeing a dissatisfaction with the future that we were offering them. We'll give you endless war. We will let the bill come to you. You will earn less than your parents. The climate, the earth is dying. And you have young people who are really, there's a certain pessimism that we are passing on to our younger people, and we don't clearly know, it's not, and we don't even know the full cause, but it's manifesting itself in many other ways. Something more even recently with the pandemic that we're seeing is that as students are coming back to class, I'm talking about students who spent 2 years in lockdown as juniors and seniors in high school. A paper in the Inside Higher Ed has the interesting title is basically, young people coming to college do not know how to make small talk. In other words, we walk up and says, hello, Fred, I'm Reynold, I'm from Ohio. It's good to meet you. Stuff that one learns coming of age. And the young man said, basically, I can't walk up to anybody whom I've not met on social media first. It sounds a reverse. So in other words, something is broken in the world that we're offering them. And some of the things we do, including, for example, how we create groups and mentorship relationships, but I'm not sure that's fully the answer. Students are struggling with their work, but also expectations are so final that basically to get a failing grade, not even a failing grade, to get that B instead of the A is the end of the world. Because we expect perfection. Anything less than perfection is not acceptable. So there are challenges that are manifest, but we do not fully understand the solution. The ideas of the support that they should need with their peers, but also, and this maybe I'm speculating, that in some ways we have had a bifurcation, a segregation of how generations socialize. So that young people are socializing among themselves and older people are socializing among themselves. You have to go back a ways. I do remember Kennedy's assassination, so I can go there. There was a time that even if you had a social function, right? Let's say I'm coming of age at 13 or 14, and we are meeting there, and even the whole courtship rituals, meeting people, and an older uncle or an older aunt said, you should go ask her to dance. Here's what you do. Now it is a 14-year-old telling a 13-year-old with all the insecurities that age entails, right? Trying to figure out what he does. And then there's this piece of data that says, like, maybe a good thing or a bad thing, but young people are having less sex in high school than they used to.
Yes, I read that.
As if sex is no longer interesting. Interesting. It says something is broken. That the world is not, and at the same time, these young people, they're freaky bright. They have talent, they have the abilities, and we don't survive without them. We will need them. So, and the support structures that we need to have, both in colleges and outside of colleges, are inadequate because also we don't fully understand the nature of the problem at this point.
Actually, let's just all breathe. No, sincerely, let's just all just take a deep breath on 3, and then just in through your nose and then out through your mouth on 3. 1, 2, 3. Goodness, okay. You were giving me serious James Baldwin vibes just there when you were talking about coming of age. Am I, no, sincerely, yeah, and all of that. And it's, all of you are essentially talking about how do we become good stewards of the time we have left on this earth for those who are coming behind us. That's essentially what we're talking about, right? And taking care of our own lives brings us to that question. We just do it in different fields. I want to ask you all personal questions. Do you have therapists?
I do.
Yeah.
I have a therapist, and I'm not ashamed to say it. I have a therapist, and I will like to say that it's okay if you need to talk to someone.
That's my
It's
baby.
okay if you need to, yeah, it's okay. It's okay if you need to take medication. I've had to take medication before. And, you know, I lost my mother when I was 20 years old, going into my junior year in college. And that was one of the hardest things that I've ever had to deal with. It took me 8 years to grieve her death. And I didn't know what was wrong. I had moved out here, been here 2 years, and I just would have these crying spells. And it was because I had a delayed grief process. And it took me years to really work through that, because my father had an 8th grade education, and he said, you will finish school because your mother wanted you to. So there was her death, which was a traumatic experience. And from there, it was, he put me back on a plane the day after her services. And at the time, I was in boot camp at Fort Knox, Kentucky, in ROTC, and I cried myself to sleep every night. So, of course, that's a trauma, that you lose your mother at a young age, and my sister was 14, and I had to help raise her. So it was a lot on me at a young 20-year-old. And I'm not ashamed to say it, that I needed help. And I'm so glad that I was able to get help. My sister did too. She's now a dentist. I have a PhD. We finished both our degrees one day apart. So, you know, you can thrive with mental illness. You just have to learn how to take care of yourself. No is not a bad word. You learn how to say no and set your boundaries. It's okay. One of my doctors said to me once before, he said, your illness is no different than a person needing insulin for diabetes or someone needing anything that would be a physical illness. And he said it's the exact same thing. So to answer your question, yes, I do. And I'm proud of it.
That's right. That's right. Anyone else want to?
I can answer.
Yes, please.
Well, I've been in therapy several times in my life, not currently. I even had a therapist, I think, in about 15 years at most. But I've had therapists at different times in my life that I needed. Even I remember one of the seminal experience for me was telling people in a group about an experience of mine, and then they looked at me and said, Starl, how come we've been in group for 3 years? You never told us this. I said, of course I told you about this. And as we spoke, I realized I had not spoken to anyone about it for 25 years.
Wow.
So there are times in therapy that the trauma of life coming through, have been important. My substitute for therapist is actually a friend who is a spiritual director, whom I've known for, oh God, since I was almost 30 years, from my men's group. And wherever I am, and we've not lived in the same city for many years, but we call in maybe at least once every couple of weeks. And he's older than me, he's about 10 years younger and older than I am. And first, how are you? He'll ask me hard questions. But essentially that friendship that is important, but basically, I told him he's not a clinical psychologist, but actually an industrial psychologist in many ways. But his thing is actually coming from a spiritual direction, asking me those questions about myself. That I can speak to anyone. Sometimes they say being president of something can be very lonely, but you have to have a circle of people who actually can disrobe you very easily and force you to speak honestly.
That's it. That's exactly it. Yes, absolutely.
Yeah, I think the thing that I would add just to what you were saying is, well, I'm not seeing a therapist. And I guess the thing you actually just talked about that's inherent in a lot of these conversations is you have innate trust in that individual.
Oh, yes.
Right? And I think that this is one of the things that comes up, and I think we've seen it especially in the last 2 years. So, we talk about people having concerns about taking the vaccine, right? When you apply that to mental health, I think we also have to think about the fact that pretty much today on a regular basis, we talk in communities of color and people will say like, Black people don't get depressed. Black men don't do therapy, right?
Yes.
Right? Suicide is not a thing, right? And so I think there's a part of this where, as much as we're doing all these PSAs about, well, yeah, you should get the vaccine and it's safe, we need to do that for mental health, right? How do we get people to understand? And whether it is through spiritual means, working with pastors and others, how do we get people that are trusted within the community to come out and provide that education, to say it's okay to not be okay, it's okay to get help. Similarly, like because you take a pill doesn't mean you're crazy, right? And then I think also the other part is, the first moment we hear, God forbid someone has cancer, everyone swarms in, everyone's got food, right? You hear about the person that gets depressed, they're sitting there by themselves.
That's right.
So we need to change some of that cultural expectation of what happens. And I think this is also part of what changes the narrative about, can you talk about it, can you get help? But most importantly, people don't know that there are other folks in the same room, in the same parish, yes, they've got an issue, they're getting treatment, it's working. They're actually doing really well, probably the most successful they've been in life because they did go to therapy, right? And I think those are the messages we also need to get out.
No doubt about it. Dr. Harmon, would you like to chime in at all?
Mia, I'm not actively seeing a therapist, but I got a couple of folks up here that would be good candidates for my therapy, I can tell you that. I've learned so much just listening to them. I probably have a therapist. I've been married to her for 49 years.
That's right. That's right.
And my insurance doesn't cover it. It's a cash only, but she's worth every penny. All of us need what you've heard from my colleagues here. First off, we have to destigmatize.
No doubt.
We need to tell each other that the Law and Brain Patient Provider Protection Act that just passed by the Congress and signed into law by the President is a bellwether type of legislation. It provides several $1 million for treatment recognition for healthcare workers who need help and should not be embarrassed to seek help, should have qualified insurance coverage for that help, appropriate coverage, and should not have to pay the penalty for asking for help or for their colleagues saying, Harmon, you got to take a day off. Well, I'm fine. No, you don't understand. You will take a day off because you need to take some time. You need to get your house in order. And they tell it in a loving manner, concerned manner, not threatening my license, not threatening my ability to come back to work. I should be able to ask for help or recognize that I should get some help. without penalty of doing my job, without a stigma. As you said, and it's a great suggestion, if you take a pill for blood pressure, you take a pill for hypertension, high cholesterol, and if you need it just to help you get through an emotionally challenging day that doesn't degrade your performance, doesn't label you or stigmatize you, that's appropriate medical therapy, like everything else. We need to understand that, accept it in the healthcare profession, accept it in the industry, and move forward, because we'll have a better world, a better workforce, a more productive workforce, and lower cost. And we can really approach a reduction in the complications of substance use disorder and behavioral health disorder. That's an incredible burden. It's an epidemic of its own proportion. So great conversation. And I've learned some of the techniques just listening to my colleagues here. Listen to people. Treat yourself as though you have another disease. Accept it. Ask for help without attribution or retribution. Very good.
That's it. That's it. You know, I can ask you all more and more questions because I have 4 sheets of questions, but I'm going to open it up to the audience for just a little bit. So let me invite you all, if you have questions of our panelists, we have microphones on each side of the room, and I'll give you all just a couple seconds to make your way there. And I'll also remind you, stay hydrated. Stay hydrated. We'll start on this side. And if you could just please tell us your name and your affiliation and give us your question, not your soliloquy. Your questions. Got it.
Can you hear me? Okay, perfect. So my name is Dr. Polly Joseph. I'm a nurse scientist at the National Institute of Health, and I'm a 2020 40 on 40 awardee. So my question is to Dr. Harmon. So I know that yourself and other panelists mentioned the burnout on nurses. We know what the pandemic has done to our profession. So I'm curious how the AMA is working maybe with the American Nurses Association and other organizations to come together around physicians burnout, nurses burnout. Is that something that you're all doing or have considered doing?
Yes, it is. Thank you for asking. In fact, I had lunch today. You may know that the American Hospital Association is also meeting here in the district this weekend. And I was attending a luncheon meeting with there, and getting an award from the American Hospital Association was the American Nurses Association. And their CEO was there with me and the AMA. I was receiving an award there for excellence in medicine, for working on exactly the type of issues you're talking about, helping the profession do its job through the most tumultuous thing in our lifetime, the COVID pandemic, an incredible stressful situation. So we're working in partnership with the ANA. We're going to have more collaboration afterwards, along with the American Hospital Association. I know it seems to be almost a platitude that we're all on the same team, but we really are. We really are. We have as much in common to combat chronic disease, illness, and the burden of disease on humanity as we might have in our individual scopes of practice and opportunities. Not just the administrators, but the clinicians, the nurses at every ilk. So we're working very hard. And remember, we can't do any of this without the entire healthcare workforce. Not just nurses, not just doctors, not just pharmacists, but the folks, and you heard it from my colleagues, x-ray techs, the medication techs, the respiratory therapists, folks that I call the gurney drivers, the people that are the frontline workers who can't get the day off, who don't get sometimes a recognition and honor they deserve and respect, because nobody's patient gets taken care of if they don't get taken to their appointments. They need navigators, they need all these things, but yes, it's a multi-faceted problem, and it's not just about physicians, no question of it.
Yeah, I think the only thing I'll add to that one is I think work within the American Hospital Association with AMA and others, they've actually created a WellBeing Playbook, which is essentially what each hospital can use across the nation in terms of helping find what are those best practices that are already being done and helping folks not recreate the wheel everywhere, but actually get good things done. There's an exciting project right now where the AHA is working with the CDC specifically to study the issue of healthcare worker suicide and how can we specifically prevent suicides within the healthcare workforce. There's also other work that's being done with, for example, AONL, in terms of thinking about what does the nursing profession need and how do we support nurses in terms of, yes, what does that work look like? But more importantly, how do you put that together as an overall career? And how do you think about what are those skills and attributes that allow people to succeed as opposed to burn out?
Thank you. Let's take a question over here.
Hi, my name is Ida Vaziri. I'm a third-year medical student at UT Health San Antonio in Texas. I'm here representing the Minority Issues Committee for the AMA. This may have already been discussed a bit, and maybe this is included in that best practices playbook, but I'm wondering what we can do to better support the mental health of our residents, physicians, and medical students. I know that we've talked about the global synchronous days, and I know that there's the 80-hour work weeks that are in place, but I know, like I've heard anecdotes of residents being told to log that they've worked the 80 hours and then continue to go back to work. And then there are also the online burnout trainings, but if you're already so overworked and overwhelmed, how can you even imagine to take the time to
That's right.
do those online trainings? I know at my institution, students have been stressed about taking time off for COVID based on different absence policies and different rotations, let alone for mental health days. And if they're minimally lenient for a pandemic, how can we expect them to be lenient for mental health? I know that personally, I've been very open about my experiences with therapy and counseling, and I know that that's helped a handful of individuals pursue therapy, but there's only so much we can do, like on an individual level. So I don't know if the solution is maybe having more positions for residents and physicians so that the work burden and the hours are less so that people are less overwhelmed. But yeah, I'm just wondering, what can we do to better support our residents, physicians, medical students?
It's definitely a policy advocacy.
Want to start, or?
related
Go ahead.
question.
Sure. So a few things I'll mention. I think in terms of helping medical students, interns, residents, fellows, first I just start off with, there are things that are already there, and I will say by the accreditation authority, every hospital, every program, every institution has a designated official. And so I think there's an education that can happen in terms of here's what you do when it doesn't play out well within your own program, your own medical school, your own hospital, your own location. And so that's without doing anything new, there's how do you redouble those efforts, right? Within the American Hospital Association, I know that we're working in collaboration with other like-minded organizations to say, there's this, you mentioned increasing slots, and both for direct and indirect, there is support to say we need additional training slots, not simply, yes, for that piece that you're talking about, but also because of what Dr. Harmon mentioned in terms of how many physicians won't be in the workforce. We're talking about mental health. Literally within the next 10 years, half or more of all practicing psychiatrists won't be in the field. What happens, right? When you look at nurses, when we look at just the next 2 years, 25 to 30% of all practicing nurses will leave the field. And if they're hopeless, and some of them leave 5 years earlier than what the projections say, that number climbs to 40%, right? So the other part of, I think, what needs to get done is beyond more slots and beyond making sure people are doing the right thing, it's really how do we change that culture within? That's a much deeper, harder problem. But I think, as Dr. Verret was talking, our simple, like, oh yes, we'll have a mixer, no, we have a different generation of people that do things in a different way, right? I was actually a resident when that 80-hour rule happened, and I kind of started my residency without it, and I finished my residency with it because of a case in New York where I trained. And it felt like it changed the world, right? Yeah. And then you have things that work backwards. And so I think, once again, it's time for that pendulum to swing again, because otherwise we're not going to have a medical workforce.
And I'll tell you, in addition to what Dr. Trivedi is saying is, it's not just putting more GME slots into the opportunity so we can produce more practicing physicians. We're producing 3,000 to 3,400 more medical school graduates right now that we have residency slots for. So these are physicians that could be in the workforce, they just can't get in the workforce. I mean, that's lunacy. And you talk to the legislators, the regulators, Congress, and the local legislators, you say, we need more doctors. They say, well, you want to know the medical school? Let's put one. We need medical students for sure, but what we really need is a way for medical students into the workforce to become residents and fellows. That's one solution, no problem, no question. So we need more of them. But to your point, and to the point the AMA is speaking for, and the House of Delegates has had policy about this, we need structural change so that the systems understand that you can't put this much on a human being. You've got to assign more people, and it costs our hospitals money, costs our healthcare systems money, and you hear that from the AHA folks. They're not just whining, they're serious. They need some payment considerations so that the funding of paying these extra FTEs that allow the workforce to meet the needs of the patient and the healthcare demand so that you're not so burned out. Even if you're limited to 80 hours, these are 80 incredibly stressful hours. I've worked as a hospitalist. I've worked for 7 days teaching my PGY 1, 2, and 3 family medicine residents in a community hospital, emergency room, inpatient ICU. We only have one intensivist in our system, so I'm a part-time intensivist too as a family medicine doc. And these residents, I saw it in their eyes. I've been in combat, I've seen battle fatigue. These physicians had battle fatigue. Battle fatigue. And they were just going through the motions, and I looked at it, and they were dealing with the emotional distress of 40-year-old folks dying from COVID, and watching their families come to their side and having to be in full PPE garb, and having to communicate. And you know how difficult it is to communicate like this, and try to tell someone you love them. Both ways. It's emotionally grueling. And these folks studied duty, did it every day, but we need to realize the system is not designed to support that level of intensive care for that long. We need to have structural change, we need to staff it up. We just talked about right now, that's almost a perfect storm. We need more staffing, but we're short of staff. This takes systemic change. It has to happen now. We don't have the time to let it continue. So the future can't be as bad as it is today. I'm an optimistic, a perpetual optimist, pathologic optimist. We have the skill set. We just need to recognize it, set a plan in motion. We're trying to do it incrementally, to Dr. Trivedi's point, and get in a better place.
Just taking notes. Yes, please.
Thank you. I'm Liz Valencia. I'm with the AMA Minority Affairs Section, Chair of the Engagement Committee, also National Hispanic Medical Association Scholar, and I serve as the Dean of Diversity, Equity, Inclusion Enterprise-Wide for Mayo Clinic Alex School of Medicine. It's an honor to be here. You're gonna have to forgive me because I'm gonna be really raw and direct. I need to know what the plan is from leadership, policy-wise, federal, national level, statewide, advocates, coalition. What are we doing to change the game for mental health services for our trainees? Student affairs is not enough. There are many medical schools across the country who are doing different modeling where they actually have mental health professionals that are providing free services to our trainees and even our faculty on a confidential basis. But yet this seems to be like a buffet menu style. Everyone's doing their version of what they think is enough, but in reality, we're not even close to bridging the gap. And our old model is based on student affairs, do external employee assistance programs, but what we know now from the pandemic, what we know now from what's happened in this country, it's not enough. And even if for our faculty, and I'll be brave and just say it out there, just put it out there. I have lost several family members to COVID. I also have lupus, and I'm trying to navigate the stresses of trying to be healthy, to be in the front lines and advocate for my students, for residents, for fellows, for my colleagues. And then we have this pandemic, And then we have lack of communication in our institutions and organizations. And yet we come to work every single day trying to show up for everyone. And what is the organization, what is medicine doing to implement fundamental change, not a buffet menu style, not what you think or you feel is the answer, but actually requirements, actually enforcement of, you know what, our old model of academic affairs, student affairs, now we need mental health services for all. How do we normalize that? How do we protect each other? My students, my trainees see me. I'm a role model for them. And if I don't feel comfortable going to seek services because of confidentiality, if I don't trust my organization, if I don't feel safe to think that there's no trickle-down effects to my job and my employment security or where I go next, you think my trainees are gonna uptake those services? So I would really love to hear what the plan is to change the game now that we know that what we have rolled with is insufficient. I would really love to hear how we're going to lead going forward. Thank you.
Thank you. Let's hear from you, Dr. Wright. You look like you were.
Everybody's
fine.
looking at each other.
Yeah.
Liz,
I'm
Liz,
fine.
thanks. I think Dr. Anderson has some, I'm not trying to put her on the spot, but when I was listening to her talk about her experiences and her perspectives, I think there's some answers there, you know, some executable plans that all of us, to your point, we have a menu of options, but some of it needs to be directed therapy, needs to be directed care. And I liked where you were going with your conversation. I'm not trying to put you on the spot, but.
Okay. You know, I was thinking as you were speaking, sometimes you have to be the change that you want to see. Sometimes you can't ask people, where are the answers? You have to come up with them yourself. You've eloquently spoken about the problem. What are some of the solutions that you can create? Is there a coalition at the job? Is there a task force that you can do at your hospital? Where can you find some points of entry to begin to have the conversation? And you know, I had a good friend who was mayor of the District of Columbia. His name was Marion Barry. And Marion and I were best of friends. And one of the lessons he taught me that I'll never forget is, he said most people his staff would come to him with 75% of the problem and 25% on the solution. He said, but I tell my staff, come to me with 75% of the solution and spend 25% on the problem. And we have an ultimate crisis going on, not just here in America, but abroad. And perhaps this is your moment for such a time as this, as Dr. Harmon mentioned, to stand up and be a leader and take some of the ideas that you have and turn these solutions into problems into solutions. And you can use your pain and your passion to turn it into a purpose. And I just think that hopefully you will leave here and find a way to answer some of the problems in your institution, because people need you. And it sounds like you are a leader among your peers. And I would challenge you and I would charge you to take this as an opportunity to find a way that you can lead people through this perilous time.
Yeah. Mia?
So first of all, I think we all felt your pain as you were speaking, and we want to just collectively acknowledge that we appreciate you getting up and being on the microphone, for sure. Dr. Anderson's right. The pain that you carry is purposeful, right? And what I first want to just encourage you in is that I think we were talking about trust earlier. We've been talking about hopelessness and we've been talking about humility. your superpower is that you're able to be vulnerable, right? It took a lot of hope and courage for you to get up on the mic and say what it is that you just said and to hold people accountable. That's a muscle, right? That we have to continuously hold each other up to keep that muscle strong and ensure that it doesn't atrophy. We've been talking also about burnout, right? So, and maybe this is also an offline conversation, that I'll put myself, I'll say this publicly, as Chief of Staff to a member of Congress who does have power and influence with respect to advocacy and policy. We can have that conversation off stage. Some of my colleagues are also here. I'm putting them, where are they at? Miss Kelly's staff is here. They're working for sure, but we're here. And so she's the chair of the Health Braintrust. We take mental health in terms of actionable items in policy very seriously. So let's have a conversation, and we can connect with other offices. Dr. Anderson used to work for a number of members in Congress who also carry the mantle with respect to mental health, and specifically when talking about BIPOC communities, and especially talking about those who are going into medicine. So that's my answer right now.
Yes, can I offer one other thing? One of the things that Liz has asked about, and I find it in my experience as a practicing physician, not a psychiatrist, not a behavioral health specialist, but I think most of you know in the real world, at least half, if not 2/3 of behavioral health does in a family medicine office, in a primary care doctor's office. And it's because of stigma, it's because of availability. In my county where I live and worked for 40 years, I haven't had a psychiatrist, licensed psychiatrist in my community for over 25 years.
That's the problem.
Zip, nada. It's because of workforce, economics, where we live, insurance coverage, the lack thereof. So I'm a psychiatrist, not by training, but by experience. And I learned to try to help. And what I really need a psychiatrist for, this is one of the innovative things that we've had now with the cloud of the pandemic, the silver lining of the cloud, is I do digital health. I get a psychiatrist on the TV, and we can have my patient get a one-on-one with a psychiatrist who can understand what's going on and help me with the diagnosis. And then once I get a diagnosis, they can direct my care. I can be an extension of the psychiatric care, integrated behavioral therapy. We advocated at the AMA because we need integrated behavioral therapy in all our primary care offices. We need it funded, we need it organized, and we need it recognized without attribution, without stigma taken away. And people, you'd be surprised, they'll talk to a psychiatrist on the TV, but may not do it in person. It's a little bit impersonal, and you feel like, well, I'm kind of sharing my deepest secrets to a TV screen. Not the same as somebody in person. Hey, let me tell you a secret. I mean, I'm telling you, it's a big deal. But one of the things we also need, to your point, I think it has to be a little bit menu-driven because we don't have the science yet to know what's the best answer. We're also asking for behavioral health, not only delivery, but behavioral health research. That's part of what the AMA is advocating for. And I think all of us are asking for the same, especially among communities of color. It's under-recognized. You hear that. Black men don't go to the doctor. I mean, I have to see their spouses at football games and at social events, and they say, Doc, get Raymond in because he hadn't had a colonoscopy. And Raymond says, oh, I don't know. I said, Mr. Raymond, come on. I'm going to see you next Tuesday afternoon, 3 o'clock. Yeah, I'll give you a doctor's note for work. You come in. And 10 years later, Raymond comes up to me at a softball game and said, Doc, you saved my life. I got that colonoscopy, and I'm walking here today because that ball game. God, chills go up my spine when I hear that. But I'll tell you, we don't know the research. We haven't done enough. We haven't invested a lot in behavioral health research. So I don't have a better menu yet, but I'm getting there. We're all getting there.
What I'll also finally say is there are people, so this is the first time this summit is live streaming. So there are people, my cell phone is on my right. There are people who are texting me right now who are saying, I'm willing to work, and who are mental health providers. So people are watching, people are responsive. So I mean it when I say let's connect after this. Thank you so much. We're going to take as many more questions as possible. We go? Okay, sure. Let's keep going.
Good evening. I am Neva Lubin Johnson. I'm a general internist from Chicago, former chair of Minority Affairs Section, former of the AMA, former chair of WPS of the AMA, and the 119th president of the National Medical Association.
She's superwoman with basically.
Hey.
But I will
Who
say,
knows how to hang up her cape.
There we
who
go.
closed her practice in 2018 when I became president of NMA, and since then have chosen to work part-time and locums. And I want to give an example of a best practice that could probably be transferable to medical schools. First locums assignment I did the first 3 months of 2020 was at a federally qualified health center in Chicago. And I'm gonna call it out because I'm talking about it in a good way. Chicago Family Health Center has 5 sites. What they do is all patients have to have a, PHQ-9 when they are seen. And if they score in a means that says they need to see someone, there is someone on site that comes down and sees the patient before they leave the facility and talks to them and allows the patient to make an appointment to see them for follow-up of whatever are the issues that they've spoken about. And I really think that this is something that could be expanded potentially to medical schools, and medical students or residents and fellows get screened every year or periodically, and then have someone on site that they can interact with. I'd also like to say that, just as Dr. Harmon said, we got taught in internal medicine, 50% of what goes on is supertentorial, okay? And meaning you're the mental health provider. And we have to, as physicians, know, we have to learn to say no, but we also can't do everything. What you missed earlier, Mia, was that same physician talking about her best friend from medical school died of metastatic breast cancer 8 months after they graduated. And so we can't do everything for everybody. Don't even try. There's no S on my chest or yours either.
yes, ma'am, you're right.
And in the last 8 years of my life, I have developed 5 autoimmune illnesses. Okay? And so the struggle is real, but knowing when to say when is real also. And so we have to be serious about truly some self-care and knowing when to say when.
That's it.
Bless you.
Dr. Lubin Johnson is the type of person, friend, whomever, who will remind you, take care, right? And I
Let me say
appreciate
this.
that.
Mia is serious about her congressman that she works for, who's my friend. I think part of it is because Congressman Kelly's husband was my med school upperclassman when I was there. And so I think she has that perspective also. The lot of the issues you've seen come through Congress with maternal health is because of Congressman Kelly. And I think with mental health, it'll be the same also.
That's it. Thank you. Yes, sir. I've seen you in the elevator twice today.
Hi, I'm Bakari. I do user experience work for NMQF. It struck me as I was listening to a lot of the things that, were surrounding people's stress and anxiety, before and after COVID, if there is an after. It seems like a lot of them, lack of access to childcare, you can't pay your rent, you can't afford food, you can't educate your children, you can't afford medicine. It seems like so much of it is caused by the fact that these things that people need to live, that they will die without, are so gatekept by poverty. And it's not profitable in the short term for them to be catered to or serviced. And any attempt to try to get systems to understand that investing in people will lead to long-term success. Also climate, it is very much driven by the drive for short-term profits. And that stresses me out a lot. But it seems like any attempt to orient systems towards that long term is met with extreme resistance. If public funding is used to incentivize private companies to make these sorts of changes that will help solve these core issues, it's increasing the deficit, it's socialism, it's such and such. And it seems so intractable sometimes because of that resistance. Because I don't know what can be done about that resistance to spending money on these things to take care of people. I'm curious what ideas you have about that.
As I listen to you and I hear that, what I hear from not only my sons, but also my students, that things are not changing and things are not changing fast enough. And I do hear what you're saying, and that's probably the more profound truth, that a lot of the struggles that people have in mental health and also in even their other aspects of their health are determined by structures in our society that need to be changed. Poverty is a big barrier. Lack of education is a big barrier. Also, it's not lack of education. Everyone goes to school in the United States, but good education versus great education versus okay education, which most kids get. All those structures are in the way. I do think social structures have to change, and they do change. And they do change because of our refusal to let them persist. At least I do remember there was a time when couldn't come down to Alabama or to Louisiana and be married to somebody who was a different color than me. I can remember that time. I was younger, I wasn't getting married at that time, but there are people like that. But I remember things in places I could not go as a young. Some of that changed. Our politics is changing. And I think what you're seeing, major changes in this country right now that have already occurred that people are resisting against. The country is changing and I would actually look in the incremental, isolated benefits and get some hope, because there's a lot of that going on. Yes. It hasn't coalesced yet. I think he's right. And I would say that same worry about the future, I think, was there when I was coming out of college in the 70s as well. That I remember, in the middle of a war, we're going to fight a war, we're going to Vietnam, everyone's in Vietnam, and then basically we're going to die.
Right.
And then we're going to want to conquer the entire world. And so we found another way. Now, it doesn't mean everything goes away, but we push against those structures. And someone, the gentleman who actually worked on DEI, on diversity inclusion, it wasn't called that at UCLA, Rodriguez. And he once said something to many of us. At one time he says, we're having a conversation in this room. He was talking to academics, professors, teachers, things like that. We're having this conversation in this room, but understand there's an old Arab proverb that says a caravan has moved on, but the dogs keep barking. Understand that what we're discussing right now are the concerns of our generation, but in our colleges, those kids have moved on. They're seeing things differently. Just look who they're dating. So the world is changing in some ways, and basically I think the younger generation is pushing hard, and what you're speaking of, I think, is coming from that, and I think we need to be pushed. I think we have to say that the way that we are doing are unacceptable, and we push for that change. It will happen.
We're going to take 2 more questions. And for those who aren't able to ask their question, please write it down so that we can pass it on to NMQF. Yes, please.
Good evening, everyone. I'm Dr. Yolanda Hancock. I am a pediatrician, a public health expert, and most importantly, a mommy. Even though Maryland is my state in which I reside, Louisiana will always be my home state. In 2020, the Journal of American Medical Association tweeted that there is no racism in medicine. Can you please speak to the role that racism plays in mental health, particularly within the Black community? And what is the responsibility of the healthcare system to create an anti-racist system, both in training and in how we treat our patients?
Obviously, this question is going to go to you, Dr. Harmon, but can I also say, thank you for that question. I was working for the American Medical Association when that JAMA article dropped, and there was such energy inside and out to push to open that conversation busted wide open, right? And there is a new editor at the helm at JAMA, right? July 1. I see Dr. Edwards is shaking her head hard. So if you don't know these three right here, if you do, you do not. These three right here, you need to have a conversation with them right here. Yes, Dr. McDade, Dr. Edwards, Dr. Lubin Johnson, for sure. But I'll shut up for now.
Put them on the spot.
Yes, put them on the spot indeed.
Mia Keys has the answer. She's right. It was, I don't know if it was a tweet. Was it a podcast?
It was a podcast. That's right,
Podcast.
Dr. Harmon.
Just to be technical, and I'm not real good at either one of them. But and we were already changing, and I'm not trying to segue the conversation. That was not a good moment for medical journalism. It wasn't a good moment for the AMA. We have changed. We have a new editor-in-chief who takes over from the University of San Francisco, University of California, San Francisco, 1 July. Well-renowned expert, real qualified. And we already had our diversity, our health equity document. We already had a Center for Health Equity formulated before we ever had that. So we were moving in the right direction, recognizing that there is structural racism, systemic racism. We've acknowledged that. We have it in our health equity document that I'm the champion for. In May of 2021, it came out on May the 12th when we released it. We have, as part of our acknowledgement, we have a 5-pillared plan. I mentioned it this morning at breakfast. We talked about it. And the 5th pillar of that plan is to make sure we acknowledge that there's an opportunity for racial healing, reconciliation, and education and path forward about the AMA's own impact on structural racism, systemic racism, and the current impact it has on today's healthcare disparity situation. So I think your point is well made, Yolanda, if I could call you Yolanda, and talk with offline, as Mia Keys says, with my health equity task force champion and chairperson, Willard Edwards. She'll answer some of those offline, but they're very serious questions and you bring it up appropriately. Thank you.
Dr. Knight.
Thank you. Last question. Dr. Knight, internal medicine, obesity medicine, associate chief of quality and population health at GW, AMA, NMA, all of those folks. So quick comment, when we talk about mental health, particularly around physicians, I remember as a resident, we lost one of our residents during residency. I remember very distinctly that morning coming in for sign-out rounds, and one of our interns did not show up for sign-out. And it was hours later that we were called together to the boardroom because they had found his body after he had jumped out of his apartment in New York. And that year we had multiple actually residents in New York who had taken their life. And as we've continued through this, even thinking to the question, Mia, that you outlined, how many of you are in therapy, understanding that many states require for physicians to disclose when applying for licensure if they've ever had mental health therapy. And so when you think about an opportunity when we're in a pandemic, myself included, who have never had to deal with therapy, and then with everything on top of us, have seeked that out, and then understanding that if I'm in a state that's required, I can't even apply for my license as a physician without saying, yes, I did have to have a therapist talk about mental health, and then have to explain that, and then is my job on the line for even seeking that? So how can we, as a society, want to say, you know, yes, healthcare heroes and get the help that you need. But if you get the help, you got to just put it on your licensure application because your job may be on the line. How do we address that?
Can I answer?
Please.
I think that's a great issue that you raised as a former congressional staffer. Those are the types of pieces of legislation that you go to your member of Congress and ask them to introduce. Because perhaps there needs to be a federal piece of legislation that would ban states from being acts of providers, whether or not they had to seek mental health services. So that may be something that you can discuss with Mia through Congresswoman Kelly to think about introducing that as a bill and to get enough support. There is a docs caucus, a congressional doctors caucus within the Congress that is comprised of physicians such as Congressman Michael Burgess, Congressman
Ruiz.
Ruiz from California. There are several physicians that are in the Congress that you could take that idea and see how you could turn it into a piece of federal legislation.
Yes, sir.
And Michael,
That's right.
Michael's also the chair of our Governing Council Minority Affairs section as well. Michael, you're right. The AMA is supporting this. We've had conversations both personally and professionally with the Federation of State Medical Boards, asking that question be, if not stricken, at least handled confidentially and not impact the ability of someone to get a license. Because you're right, the only option you have is to lie, not reveal it, and then that by itself is a lie. And then you can be held accountable for having a false application. You can't win. You need to be able to say, I've had therapy, I've taken it, but I'm still able to be a doctor. I'm a critical part of the workforce. And if nothing else, you might be a better doctor because you understand that lived experience of getting therapy and recognize it. I mean, think about it. I mean, I'm a better doctor because, but because I'm a better doctor, now I can't be a better doctor. That doesn't make sense.
Right.
Thanks.
I might add another one that, to take it to a larger point, that I think as we speak to our legislators and to our government, I think there is a need for associations to begin to speak to enlarge our privacy laws and really tighten them. Because the idea that basically that anything that I use to seek healthcare could be accessible and used against me in a certain way because of some exception, some loophole in the law that allows it to be accessed is something that creates an issue. And I'll take a larger piece that as we're moving into, let's say, genomic medicine, that my genotype will be affected, my physician will actually sequence my DNA and put them into his supposedly HIPAA-protected database, which is still accessible by someone. At least I know some 18-year-olds who can crack any anonymity. I do know those 18-year-olds. They go to MIT. That if you do not have some really overarching privacy laws that are very tight, you make people inaccessible. I'll take the example of the All of Us movement program that the NIH is pushing. And the All of Us will have great benefits for us, but people who are refusing to access that because of some insecurity that I'm giving too much. Unless there is clearly an impenetrable Chinese wall that says the data that I give can never be used in any uncertain way, I cannot fully give it. So I think it is important for the health establishment to think about how you establish privacy laws that are much tighter that other countries actually do, for example, in Finland or in Denmark. That we cannot say that, oh, maybe these researchers may need access to this data, or this company may need access to this data. So we need actually ways of protecting the people so that they can actually be freely able to give their data in some way. And I don't have the answer to that, but unless we do that, we'll always have these gaps in our space.
And to work with trusted, oh, yes, please. And to work with trusted organizations like the National Minority Quality Forum to ensure those practices. We are running short on time, and this is a phenomenal conversation. Before I invite our panelists to give us our marching orders and their final words, I just want to acknowledge the healthcare providers, and particularly in mental health services, who are in the audience. If you all would not mind standing to your feet, and this is me putting you on the spot, you do not have to, but I see a good 4 or 5 of you for sure. So you are welcome, please. You better stand up. Yes, you are. Yes. Yes, you should. If you don't know each other, perhaps you feel inclined to connect. So maybe you should just look each other in the eye, give a wink or two. Okay, great. This has been phenomenal. I want to continue. Let's be friends, something like that. Closing words from you, Dr. Harmon, and then we'll just go straight down the line, please.
Thank you. I think, you know, I'm serious about what I'm doing. I consider it a real honor to be a doc. I've been given a gift to be a healthcare worker. I'm married to a career nurse. That's why she's qualified to be my therapist. We both took oaths, and I just take it real seriously to be a doc. I think that's a blessing to have the skills, to have the opportunities. You know, for small town America. My dad died when I was young, so I had a single parent mom, and she encouraged me to do what you heard from my colleagues: get that education, because you have a gift, and all of us as healthcare providers have that gift. I think all of us are here for the right reason: deliver quality health care for our nation, our community, and our world. And embedded in the name of this organization is quality. You know, this is why we're here. So it's an honor to be here to ensure we get quality, equitable quality, appropriate quality, the right delivery system. Honored the AMA is represented, honored to be part of it, and just real proud of all of y'all. Thank you.
Dr. Anderson.
Thank you. In closing, I think I want to leave you with a few words, and that is, it's been an honor to sit here before you and talk about my personal story, as well as my professional walk at Vertex, being there for 1 year. And it's okay to ask for help. My company is extremely sensitive about creating a culture that fosters our ability to speak up, to say, hey, I need to take today off, I'm burnt out. And I would challenge each and every one of you, when you wake up in the morning, and if you put your feet to the floor and you say, I just don't have it today, whatever you do, stay home. It's okay. It's okay. The world is not going to fall apart, because believe it or not, it's not being held by your back. So, you know, we are the empaths of the world. We are the people who feel people's pains, and we want to help fix people's problems and solve their problems. But as they say in the airline industry, put your mask on first before securing others. So I would encourage you all to do that and be compassionate, not just to other people, but most of all to yourself. Thank you.
Goodbye.
Dr. Trivedi.
Sure. So I'm going to go back to that comment about being the optimist, right? And the thing I'm going to say is, the silver lining in this COVID pandemic experience is we're all actually sitting here having this conversation, right? So the point is, there's never been a greater time where people are more aware of how much mental health is an issue in their own lives, in their own family, in their own community. And what I would say, you know, to the gentleman that was frustrated that not enough is happening, or what's going on, or how do we fix medical schools, or what do we, the job of every generation is to push forward, right? And so what I say is, yes, if you wake up in the morning and it's important to stay home, stay home. But if you've got an ounce of push in you, I say live life with intention. This is the moment in which we have to push for something different. And what I mean by that is simply, we can't go back to a day where people can't talk about their mental health struggles. We can't go back to a day where the person that has the mental health issue in the family is the one that's kind of the black sheep or not talked about. We can't go back to the day where you get all the stupid, you know, pull yourself up by the bootstraps and do this and do that. We all know it doesn't work, right? And so now the point is, how do we get to change? And when we talk about change, this is the other part. If we think about everything at once, it becomes super overwhelming. I know, because that's what I do all day long, right? But you break it down. So when you talk about, well, what about the kid that isn't able to put food on the table? And what I love about this group is there's a federal food program. Then you talk about the person that has difficulty, and with accessing healthcare. And I will say, I give my entire life to making healthcare, mental health care available for those that have no ability to afford it. And I say, thank God there's a Medicaid program. And I say, thank God there's all these other different things. But what I will say is, it's the last comment that Mia made, which is we all have to work together. We have to build community where we all say where we're at is not good enough. And we're gonna do better, not because I need it, because I need to make sure that everyone that doesn't have a voice, that everyone that can't be at the table, everyone that doesn't have that ability, the fact that we're all in this room, we have a lot more than the vast majority of the world. And it's incumbent upon us to make it a brighter day for everyone else and everyone else that can't push.
Absolutely. Dr. Verret.
Well, all I can say is to thank you. There's no more honorable calling for a human being than to be a caretaker of other people. That's why the story of the Samaritan resonates for the last 2,000 years. And what you've been called to do is not only to care for others, but also to prepare others who will care for others as well, and to multiply. But as you do that, you're also called to care for each other, to be sisters and brothers to each other as you do that. There is a need for peer support as we do these things, especially difficult things. I'm sure as when you were in the military, that's something that you've learned. That's probably the first element of survival. Do that, care for each other, love each other, and also have places where you can actually let your hair down, let your tears flow if you need to. And I want to think what you are doing is God's work. You're blessed. Remember that. But it's not going to be easy, but don't give up on it. Thank you.
And on that note, I want to thank you all for being such good caretakers of your word and your purpose and your actions. And I want to thank you all for being so attentive and sticking with us and giving us your energy. I personally want to thank Sharia Thompson for holding my baby while Mommy's doing the panel. And I think she's out there right now because I heard him hollering. She's still out there? Okay, okay. He is super cute, right? Yeah, thank you. Let's continue to take care. Let's continue to do the work. That's the only way we can do it. Thank you all. Have a great night. Please come back and join us again tomorrow.